Hi everyone, welcome to today's LACNETS webinar. I'm Lindsay Judavine, the Director of Communications for LACNETS, and this is...
I'm Lisa Yen. I'm the Director of Programs and Outreach for LACNETS.
Before we get started, I'd like to take a second to thank Rich at TVP Live for making today's webinar and high-quality production possible. We'd also like to thank our supporters, Ipsen, Advanced Accelerator Applications, Tercera, and Novartis. Also, be sure you're following us on social media. Stay up to date on upcoming webinars and net news. We're on Facebook, Twitter, and Instagram with the handle @LACNETS. Now, before I pass it off to Lisa, I'd like to remind our viewers that these webinars are done for educational purposes only and do not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. And now I'll pass it off to you, Lisa.
Thank you, Lindsay. LACNETS is a program by GeneratePossibility.org, a registered nonprofit, and LACNETS stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. Our mission is to provide education, advocacy, and support for all people impacted by this rare disease that used to be known as carcinoid, an old term meaning cancer-like. The more accurate term is neuroendocrine tumor, or NET for short. You'll often hear us say neuroendocrine cancer, as it's a patient-friendly way to say the official medical term, neuroendocrine neoplasm. We also say neuroendocrine cancer because we understand NET is a type of cancer and not cancer-like or benign as previously thought. While you often see Lindsay and I leading the meetings and programs, we are led by a team which includes our Executive Director and Board Member Kavya Vellakkapudi and Board Member Donna Gavin, who is also the sister of LACNETS founder and Executive Director Emeritus Giovanna Joyce Mbasi. Our board also includes Mary Dunleavy, who has been living and thriving with NET for over 17 years. Before we introduce today's speaker, we would like to share with you our What is NET video. You may have already seen it last month as we premiered it at the beginning of our annual conference. This video sprang from discussions in our weekly support group about what to tell friends and family who ask, what is NET? What is this type of cancer we're living with, and how do we explain it to them? So we created this 5-minute video so you can share with your loved ones as an answer to their question. What is NET?
As a patient, I often am asked, what is a NET? I mean, what is it that you have? What type of cancer is this?
I've been explaining what NETs is to family and friends for a number of years now, and I found it pretty challenging due to the unique complexities of our specific cancer.
NETs has been the process of learning how to engage with that initial diagnosis of a tumor cancer, and then realizing and trying to explain to friends and family that the words remission or you look so healthy don't necessarily always apply to our unique category of disease.
You kind of have to go to the right places to get to answer some of the right questions, and sometimes you're not even sure what question to ask.
This is not the cancer that everybody's used to hearing about, especially a patient that has pancreatic neuroendocrine tumors. This is not pancreas cancer. A neuroendocrine tumor of the rectum is not what you think about when you hear rectal cancer.
Most of the time when patients develop cancer, it's in the lining of their internal organs. And the lining of the internal organ yields a cancer called adenocarcinoma. So 95% of the time, that's what we're talking about. However, about 5% of the time, there are hormone-producing cells that are either heaped up in your glands or it can be scattered in your organs like your lungs or your small bowel. And those hormone-producing cells grow for whatever reason, we don't quite know why.
These are tumors that are produced by special cells in the body called the neuroendocrine cells. The way they call neuroendocrine is because they produce hormones, which can produce the symptoms that we talk about.
They're slower growing cancers than other cancers that we care for, and they're cancers that can start anywhere in the body. I always tell my patients there is nothing they did or didn't do to get this problem. We truly don't understand why they develop. There tends to be nothing that we can see in the environment or in the diet Very, very rarely or from an inherited gene, but that's super rare.
Most of the data that you will read online about lung cancer and pancreas cancer and rectal cancer, colon cancer, really does not apply to neuroendocrine tumors.
And neuroendocrine cells are the cells that actually make hormones, because we have neuroendocrine cells all throughout our body.
And because they're slower growing, sometimes we don't know that they're there until much, much later than when they developed.
So compared to traditional cancer, we might hear about they take years and years to get to the point where they are, and people can live with those cancers for years to come. They cause everything that a typical cancer does, and actually more, because sometimes you have hormone symptoms that come with it, and that's an extra added burden which most other cancers don't have. But here, instead of things happening in a year, 2 years, it just takes longer for most of the things to happen.
And so I think the thing about neuroendocrine tumors that's maybe different from other types of cancers is the heterogeneity of them.
They can make hormones or biochemicals that can make people feel sick, and that might influence the way that they feel and their quality of life significantly. Because of that, we treat those tumors or cancers in very different ways, where the goal is really about getting control of the disease, much like we would control of a chronic disease like diabetes or hypertension. It's still cancer. We have to treat it accordingly. We have to manage you accordingly. And it's something that we can deal with, but it needs to be dealt with.
Most patients with neuroendocrine tumor can live long, healthy lives, even if they have more advanced disease. And so not all hope is lost, and they just need to get into the right hands with the right group to get more information about their specific tumor. And then that will tell us a little bit about how long you're going to live and what treatments we can give you to try to extend that as much as possible.
We may not be able to get rid of all of it, but we might be able to control it for years to come with different type of treatments. That might involve a lot of different therapies, either combined together or sequenced together over time.
While NETs isn't often curable, it is treatable. And the treatments aren't like other cancers, where your hair falls out and you lose a lot of weight. There isn't a clear algorithm, and people are often in and out of treatments. And there's often a lot of decisions to be made.
But I think the most important aspect of neuroendocrine tumors is looking into the type of neuroendocrine tumor you have and understanding how that's going to impact life over time.
Going to a doctor that really understands the disease is critically important so that we could better understand your tumor and what we need to do for your disease.
It does have a rich community of people diagnosed with the disease, and so I think really reach out to others to learn more about the disease.
So definitely talk to the NET advocacy groups, physicians, and other patients to kind of get more information to really get started on this path that you're heading on.
My husband is living with the same type of cancer that Steve Jobs and Aretha Franklin had. But while celebrities might have made NET famous, it's important to know that there are about 180,000 people living with neuroendocrine cancer. So it's not as rare as previously thought. The challenge is learning to live a new normal with the disease, because it is possible to live richly and fully and to thrive despite living with neuroendocrine tumor. I'm excited to introduce today's speaker, Dr. Eric Liu, who is well known to many, including to the LACNETS family. Dr. Liu is an internationally recognized surgeon who specializes in neuroendocrine tumors. He completed a fellowship in Uppsala University in Sweden under Dr. Oberg, who is considered one of the pioneers of neuroendocrine research. Dr. Liu was responsible for establishing the first clinical trial in the United States for the gallium-68 dotatate scan, an important tool in diagnosing patients with NET. Dr. Liu was previously at Vanderbilt University in Nashville, Tennessee, where he established a neuroendocrine tumor center, and he is now the co-director of the Rocky Mountain Cancer Center's Neuroendocrine Tumor Center. Those of us who know Dr. Eric Liu know that he is passionate and innovative in helping patients. He cares about collaboration with all in the NET community. And to that end, he co-founded the Healing NET Foundation, along with NET patient Cindy Lovelace. The Healing NET Foundation's mission is to optimize care of those with neuroendocrine cancer through the education of and collaboration among physicians, healthcare providers, patients, and caregivers. Dr. Liu likes to say that his focus is always treat the patient, not just the disease. He finds that giving patients time and respect is critical to developing a sense of trust, because it is a team effort with the patient in the center. He always tells people that he values the quality of life as highly as the quantity of life, And we are grateful to have Dr. Liu join us today to give a presentation titled, How to Live with NETs. Welcome, Dr. Liu.
Hi, everyone. It's great to see you. And thanks to Lisa and everyone at LACNETS for having me on. This is really great to see you. It's always fun to work with LACNETS. They've always been such wonderful partners in the field of neuroendocrine. And of course, it all started with Giovanna. So never do we ever forget how much she's contributed to establishing the care for patients in Los Angeles and now across the country. And so it's wonderful to continue to work with you all. So welcome. What I want to talk to you about today is a little bit similar to the stuff I had talked to you about last year, but hopefully you'll see that I'm just being consistent. And what I like to talk about, I know you hear lots of these podcasts and webinars about very complicated technical things involving neuroendocrine cancer, but I really like talking to people about what it is to be that person. You know, when you have this disease and you're young and all you diagnosis, and maybe your doc knows what they're talking about, and maybe they don't know what they're talking about, and it can be so scary. And sometimes you feel like the whole weight of your life is upon your shoulders, and there's a little bit of truth to that. So I like to tell people that you're not alone. Just as Lisa just said, it's very important to measure the quality of life as well as quantity of life. And so with all those things together, then and only then can we really understand how to live with neuroendocrine cancer. And that's what I'm hoping to talk about today. But if anyone's interested, please feel free. The wonderful library that LACNETS has developed of videos is fantastic. There are quite a few actually of the groups who have these kinds of seminars and videos. So I think there's a wealth of knowledge, and we'll touch base on that in a second. But for the next half hour or 45 minutes, I do want to talk about kind of how I see living with cancer, because I know lots and lots and lots of people with neuroendocrine cancer. And unfortunately, we've lost, and many are thriving. And you've seen that even in the past 10, 15 minutes with the introductions. Okay. So I do have a couple of disclosures. So this talk is 100% a do as I say, not as I do kind of talk. Okay. I'm not gonna lie to you. Okay. And all the patients know I never lie to them. Right. So here's the deal. I don't sleep enough. Right. I did surgery till late last night. I eat junk food all day long. I eat junk food all day long, right? Because that's all I can eat. Right? I am stressed out all the time. You would be surprised at how difficult it is when people are constantly asking you what to do all the time. I do not exercise enough. I tell people all the time, the risk-benefit ratio of exercise is still a little bit dubious to me, so I don't exercise. I definitely wish I spent more time with my family because I'm trapped here all the time. I wish I spent more time for myself because I guess I haven't read a book in ever, maybe. I know it's been a long time. And I am tired all the time. And so that is not what I want for you. Okay, so I just make that very, very clear. And I will tell you, I am not a social worker. I am not a lawyer. I'm not a hospice specialist. I'm not an insurance specialist. And I'm not a healthcare financial advisor, right? So I'm not a specialist in any of those things. But there is no question having the resources and talking to people about all these things is actually very, very helpful. And so I will tell you how I see it and how I feel about it, and hopefully how it affects you and how you think about it, so that you can learn to live with the cancer. So there are two words that I just want you to think about as I continue to talk about this. I want you to think about what it is to live, and I want you to think about what it is to have time. Those are the two words that I think about all the time, because I want people to live and I want them to have time. And basically that's all. That's like Lisa had mentioned, it's the quality of life and the quantity of life. So think about those two words as we kind of go through these thoughts of mine. And so I always kind of try to tell people there are things that you can control and there are things that you cannot control. And the things that you can control are actually quite long, which is great. There are lots of things you can do. It can really help you understand the disease. And there's pretty much one thing you can't control, which is the disease biology. And we'll talk about that. But you can see here, what can I control? What can I do like right now, right? I mean, look, I hate to tell you this, guys, especially all you in California, you cannot control the price of gasoline. That's just what happens. You can be upset about it, you can go crazy about it, but you can't control it, right? So it's not worth going crazy about. So don't worry about that. But you can definitely control, how do you live? What is that you're living for? You can control how you sleep. You can control how you eat. You can control what you do with your time, which is being active, spending time with loved ones, being social. But you can also control who is part of your care team. You can also control what you understand of the disease. You can control what treatments you think are best to do for yourself. You can also find support. I know I'm probably speaking to the choir here since we're here with LACNETS. But you can also control how you react to stress. And I know the initial reaction can be difficult and shocking and hard to manage. But truthfully, how you go on from that and what that stress means to you is actually very important and probably plays a role in your disease. So if you can control all the things on the left and just realize that you can't control the thing on the right, then that's actually a pretty big step. And I think a lot of the people who have kind of, thrived and flourished living with the disease understand that principle, because it's so shocking at the beginning. It's so shocking that you don't even know what to do. And then once you start to get control over these feelings by addressing the things on the left, then you begin to understand that you have to live with the thing on the right. So you see it's kind of grouped into two. So the first thing we'll kind of talk about is how you actually function day to day and why those four things are so important. At least that's how I feel about it. And then the next thing we'll talk about, how do you structure it? What is the intellectual aspects of it? What are the resources you can find? And what kind of support can you find to help you live with this disease? So why don't we start first with the most important thing? The fact is you've been diagnosed with a kind of cancer, right? And that means that you should make sure that your affairs are in order. That I should make sure my affairs are in order. Everyone should make sure their affairs are in order, right? We should have wills. We should have power of attorneys. We should have all those things declared so people know what to do. You know what's a terrible situation is when someone dies all of a sudden and there's no insurance and no one knows where the passwords are and no one knows where the money goes and it's a very, very difficult situation. So having someone control and declared well ahead of time is very important and has nothing to do with your cancer. Everyone should do it. But if this is what it takes to stimulate you and push you to do it, then do it, okay? Because you need to protect yourself for what you want to happen to you if things go badly, and you also want to protect your loved ones, okay? So I think it's very, very important. I know it seems obvious. I know we always say it, but you should do it. Okay, so let's talk about the one thing you cannot control, which is the disease biology, all right? So what I tell everyone is the zebra thing is totally right on, okay? So this is a great picture I just saw. We've been posting around the past month or so of this National Geographic picture. The shadows are actually, the black things are actually shadows of zebras. I think it's such a neat picture. But the zebra thing is totally on board. So if you've never heard the metaphor, zebras are the mascot for neuroendocrine. And the reason is because in medical school, you're taught if you hear hooves, think horses, not zebras. So that means if someone has a cough, and I know you all heard me say this before, but if someone has a cough, you should think allergies, you should think maybe a little bronchitis, you shouldn't think tuberculosis right away because people don't get tuberculosis anymore. But it is not uncommon for neuroendocrine patients to present with a little bit of belly pain, a little bit of flushing, maybe a little bit of diarrhea, or maybe a lot of diarrhea, right? So unfortunately, when you have neuroendocrine, you are the zebra. Okay, so but we have to think about that. So when I go talk to other doctors and try to teach people about neuroendocrine, I tell them, I say, look, it is true. Most of the time it will be infection, or it might be some autoimmune disease, or it might be ulcers, or it might be irritable bowel syndrome. That's true. But you can never fix anyone if you don't at least think about something weird. And neuroendocrine is one of those weird things. It's not so rare anymore. There are a lot of people who have the disease. And so we just have to think about it. So we always just say, you don't have to cure it. You don't have to know anything about it. You don't have to treat it. Just think about it, and that will get you very, very far in helping that person. But when it comes to the biology of the disease, the zebra thing works out because the stripes are so different for each one, right? That means every person is different. That means that every tumor, even within the same person, is different. That means your symptoms are different. The tempo of your disease is different. The reaction to treatment is different. And that also means that all that stuff you read on social media may not necessarily apply to you. And unfortunately, the statistics you read may not necessarily apply to you. So, for example, if someone says you have a 50% chance of survival at 5 years, well, that means you got a 50-50 shot of being there, right? But which 50 are you going to be in? It's not so great. But we can kind of figure that stuff out because we can study you, we can understand your disease, the tempo, the details really matter. So the statistics are helpful, they're a tool, but they're not perfect because they take a dynamic process, such as a disease process of neuroendocrine, and it makes it static into one little number, which may or may not have any meaning. So we just have to be very cautious about what it is that you're going to consume and how that information applies to you, and know that everyone is different. You're the zebra. All right. So let's talk about the 4 legs of the chair. Okay. So these are 4 pretty important things that you control every single day. Because people ask me all the time. They ask me about, well, what can I do? How can I help? Well, I'm like, show up for your doctor's appointments, show up for your scans, do the treatments, but do these 4 things. So the number one thing I always put on is actually sleep. I know people like put on nutrition and various other things. I put on sleep. The number one, without a doubt, the number one complaint that most neuroendocrine patients have is fatigue. And the truth of the matter is it probably is the number one complaint of everyone in this country, to be frank, or in the world probably, is fatigue. So what people don't always realize is that sleep is an extremely important part of treating that fatigue. It's probably the cause of it. Nowadays, everyone's got their phones and their devices, right? I mean, I have 2 of them sitting here, and they're always following things, and they're doing their social media, and everyone says, go to our Facebook site, go to our Twitter site, go to our Instagram. I think we just saw a slide about that. That's difficult to do, right? I mean, it's fun to do, and it's a good resource. Don't get me wrong, it's important, but it still cuts into people's sleep. So the whole concept of sleep hygiene and the importance of sleep, and I mean, we've all heard it before. Oh, I can sleep when I'm dead. Well, you will sleep when you're dead because you will die faster. That has been well documented. So getting a good night's sleep, being able to control your symptoms, for example, so that you can sleep well, making sure that you're healthy so you can sleep well. All those things are extremely important because they contribute to your well-being. And as I tell all the people who have surgery here all the time, I said it this morning, I said, your body only heals when it sleeps. And it is impossible to sleep in the hospital. So it's not that I'm trying to kick you out of the hospital. I just want you to get some rest. So sleep is super important. Right? So please don't underestimate that. Of course, there's nutrition, right? Nutrition is a challenging thing sometimes because obviously a lot of neuroendocrine is digestive and belly kind of based, right? So it's not so easy. But one thing I tell people, just eat what you like, eat what's nourishing to you, and make it a rainbow diet, right? As much fiber and color. I don't care if it's red, blue, orange, green, purple. The more you can get inside there, the better it is for you. And people will say, well, I can't eat this, I can't eat that. Oh, right, no. They say, I shouldn't eat this and I shouldn't eat that. And I say, yes, of course, there's some truth to that. But just because someone said you can't necessarily have avocado because it's on the naughty list of neuroendocrine doesn't necessarily mean that you can't eat an avocado. What it means is that if you eat an avocado, you don't feel well, you might want to avoid it. Okay? So that's what that means. It doesn't mean you can't have a little wine. It doesn't mean you can't have fiber. It doesn't mean you can't have salads. It just means that it might contribute to your symptoms, and you should be on the lookout for it if you don't feel well. I mean, last time I checked, a piece of lettuce was not toxic, although it may have E. coli in it. But if you can eat it, then you should eat it because that nutrition is very helpful. Not only is it good for your body, good for your well-being, good for your mentality, good for your sleep, hopefully, but it might also help with your diet as far as your bowel habits go, and it might also help you endure and tolerate your treatments better. So all those things are super important when it comes, and you can control that. You can control that. So people will say, "Oh, I'm going on a all fruit diet." Well, I don't believe in that. I really believe that's still good to have a very balanced diet. I think at one point Steve Jobs went on a very restrictive diet and it was not great for him. I'd rather you be healthy, healthy, healthy. How about activity? Okay, activity, so very important, right? Your body was designed to do stuff. Your body was designed to move. Body was designed to express the inner part and associate with the world. And that is super important still. It's important if you're having treatment. It's very important if you've had surgery. I think probably a majority of you have had some kind of operation. And there was a day, maybe 50 years ago, when we said, oh, just stay in bed. But now we get people up, we get them moving, we get them walking, we get them breathing, because that's how the body is designed. Your body is designed not to lie in bed all day long. Your body is designed to be up. So I tell people all the time, the more vertical you are, the more you get those lungs open, the more you walk, you can get your bowels moving. It's super important. For those of you who are not necessarily in the hospital, it's still important. Walk. I'm not saying you have to lift weights or do anything crazy like that. You need to walk. You need to be active. I don't want you to be sedentary. I don't want you to be sitting in front of a TV all day long. I certainly don't want you in front of a computer all day long or stuck to a device all day long. Movement, movement, movement. Because that helps to build muscle mass. And one of the things that I worry about, so, behind all these things are the things that I think about. Well, what is the muscle mass? How is your nutrition? How are these things? Because once your muscle mass starts to go away, that is the beginning of bad things for this disease. So activity and keep in staying strong. Take a look at last year's lecture. I tell people all the time, it's easier for me to keep you up here and doing well than to dig you out of the ditch. Okay? So if you're starting to get a little bit not so great, it's still easier for me to fix you than to lift you after you've been, sick for so long. Okay? That's the goal. Now, I do believe very strongly that we as human beings were created as a social animal, right? And so if you isolate yourself, and I worry, look, we see it all the time in the news, that if you don't socialize and you're not active with the other people, then you're going to be trapped in this teeny tiny little world on a teeny tiny little screen. And that's very dangerous. And so and it's been well documented too, you hug people, talk to people, that is a source of oxytocin, which is a very, very powerful hormone that creates these good feelings inside you. And I tell people all the time, I say, well, why do I live, right? I tell people all the time, well, my wife says, well, why do you work, right? The reason I work is to raise my children. So I'm not going to lie to you. I work just to pay for them. But why do we live? We live so that we can do the things that we want to do. We can travel. We can eat the foods we want. We can be with the people that we want. But for those of you who have sat in this office with me, you heard me say this before. I want you to sleep. I want you to have good nutrition. I want you to be active. I want you to socialize. And let me worry about the rest. Okay? All right, so let's talk a little bit about your care team, right? So now we're going to go through that list, right? And I think it's important because this is probably, as far as the medical portion of it, this is the most control you can have. So ultimately, who is on that care team? Well, you. You, as the patient, are the ultimate decision maker. UDM, the one and only, okay? Anyone who says that, you have to do this, or you have to do this, doesn't quite get it, right? Because it is what you want. We are all here to support you. We are all here to help you. I say all the time, I'm like, my job is to be your Sherpa, right? To guide you through the process. But at the same time, and it's true, I might push you into having certain things because I think it would be very helpful to you. But at the same time, if you feel that this is not for you, or you need to wait, or this is not the right thing, that is up to you. So you are always the ultimate decision maker. But another person who's extremely important, and I don't think many of you are on here, are the caregivers. The caregivers are so critically important. Spouses, parents, for older people, their children, brothers, sisters, friends, partners, just everyone. The caregivers do so many things. They're scribes, right? They come in here. They're the ones that write things down for you so you can remember. Sometimes the treatments make you a little kooky or you can't remember stuff. You get a little bit of brain fog. I know you've all complained of that before. They're your advisors. They hear what we just talked about. And they say, well, maybe we can try this or this. Maybe this will be good. But ultimately, you have to decide. And really, it's good to have a second brain, right? I have been married for 24 years. I only have half a brain because my wife has a brain and a half, thank God. And so I'm with her all the time. So if I ever didn't have my wife, I'd only have half a brain. So sorry, gang. That's what you're stuck with today. So that's why the caregiver is so important, amongst many, many other things, supporting you, taking care of you, just being there to help you through a difficult time. Okay, so those are the two super obvious things. But now what about the NET specialist, right? So you've all heard me before, or you've seen me on social media. I always say, go see a NET specialist, right? I say that all the time. It's a challenge, I'm not going to lie to you, because a lot of people think they're NET specialists and then, maybe they don't have quite as much experience as you might think, right? So that can be a little bit of a challenge. But I really want you to see someone who understands the disease and look, I mean, I've seen this like several thousand times, right? I mean, after several thousand times, you kind of get it, right? I'm not perfect by any means, nor do I know everything about this disease, but I have fixed a lot of people and I've helped them and I've kind of figured things out, right? And so this is why seeing someone who does this all the time is super, super important, right? It's super important. But on top of that, in theory, if you have a NET specialist, that means that hospital should have a whole bunch of patients in that hospital at the very moment with neuroendocrine. Like we just made rounds. I think we saw 10 people who have neuroendocrine. We saw a bunch of people with neuroendocrine. But then on top of that, the whole team is here to help you, right? So having that team is super important, right? So that means that the intake person understands neuroendocrine. That means the nurse understands neuroendocrine. That means the anesthesiologist understands neuroendocrine. That means the radiologist understands neuroendocrine. That means that the food services people, I know this sounds ridiculous, but the nutritionist and the food services and the physical therapist understand neuroendocrine. No one is surprised by this weird cancer-like disease, right? And that's why you go see that specialist, because everyone knows everything about it. I mean, it happens all the time. I was just talking to our hospitalists here, my friend of mine yesterday, and he said in his career before coming to our hospital, he had seen maybe one or two cases, and then when he's here, he sees them all the time, and he feels very comfortable with it. So it's not just me, right? It's also everyone else who takes care of you that's so critical. And I'll give you an example. We have a patient who lives very, very far away from us. She lives in a kind of a rural area. She was not getting the care she had. And I told her, I said, look, you have two choices. You can either dilly-dally down there and just keep on where you are. And she was very, very sick. Or you can get in a car and you start driving to Denver. So she drove the 2,000 miles. I kid you not. She drove the 2,000 miles. She drove up here. We admitted her to the hospital. I told my friends, I said, look, I don't know what she has. I can't figure it out from 2,000 miles away. We got to figure it out. We admitted her. And we figured out that her thyroid was on the fritz. We helped her thyroid, and she felt much better when she left. So it's just that kind of thing, right? So having a NET specialist is very important. But you still need to have a local team, right? I mean, I'm still 2,000 miles away from you, or for some of our patients, we're 7,000 miles away. So it's not so easy, right? So you need a local oncologist, usually to deliver the injection. They need to order scans and stuff like that. You still need a local primary care physician because, look, I mean, I'm not going to lie to you. Like, I'm not that great at choosing when to order mammograms or to kind of do routine things or to manage your hypertension, right? So you still need the people nearby. They just need to talk to each other. It's not perfect. Despite the fact that we live in the 21st century, we still talk through facts all the time. I don't quite get it, but that's just how it is. So you also have the nurses. They're extremely important. They probably spend more time with you than I do, right? I mean, how many injections have you had where you had to sit next to the nurse while she was like warming it up or something, and you can chit chat and talk? The social workers are so important because it's financially toxic to have a disease. The medical assistants help you in your scheduling, the schedulers help you. And of course, your local hospital, because sometimes you'll be sick and you've just got to go to the local hospital. And true, they may not have all the resources, they may not have all the expertise, but they can maybe kind of get you settled, and then we can figure out where to go from there. So that whole care team is expansive and super, super important. But it all circles around you, right? The caregivers, the net specialists, the local docs, the local primary care doctors, and then everyone else circle around you. But you still have to kind of put it together. You still have to find the right people. And you have to find the person that you really feel comfortable with. And that's so extremely important. Okay, what else can you do? Well, you can understand the disease. Right? I think it's really important to get a sense of what's going on because how worried do you have to be? What do you have to do? Do I have to travel to figure these things out? You need to understand the disease, right? Because it's important to be able to speak the language, right? So first of all, don't obsess, right? Don't expect to know everything. There are people who've gone through medical school, done a residency, and still don't understand the disease, right? So don't expect to do everything because you're never going to be able to find everything. You're never going to be able to put it all into context. And what I tell people all the time is if you read the textbook word for word, you'll maybe know 25% of neuroendocrine because the other 75% happens here, right? It happens here in the office. It happens in the lab. It happens in the scanner. It happens in the hospital. It happens in surgery. So that's where most of it is. So don't obsess about it. Don't expect to know everything. And if your local team can't help you, find help. If you can't find the answers to all your questions, look, it's not perfect. I can't tell you why you got it. I can't tell you if your kids are going to get it, but I can tell you a lot about your disease. And if you feel there's just not enough being told to you, then you should probably find help through a neuroendocrine specialist. Find resources. There's a ton of resources we'll talk about in 2 seconds, but there are a ton of resources out there that you can read, not at night, because I know I want you to sleep. But there are a lot of resources that can kind of get you acquainted with this because you will need to learn to speak the language. It is a different language, right? So if you've heard from, I've been to a lot of medical talks and, I speak the language and it's still sometimes difficult to process. So you have to speak a little bit of medicalese so you can at least understand what it is. And we have resources such as Net Vitals. It was a project that was developed by LACNETS. They did a fantastic job in which you can write down all those important facts which help your physician or your care team help take care of you. But you still have to be able to gather that information. You still have to speak the language so you can understand what is a Ki-67, what is well versus poorly differentiated neuroendocrine, right? All those things are important. So that's the way that we can communicate. And the other thing too is you want to allow your caregivers to do this with you, right? So you have someone on the journey who can help and support you. And there are some people who don't have that support, and so it can be harder. But if someone can help you and be with you and go along with you in your journey, that's so extremely critical because it is too much of a burden to have it all on your shoulders. That whole team that we just talked about a second ago, we're the ones who need to help you bear the burden. So here are some resources I can tell you about right now. As Lisa had said, I work with a group called the Healing Net Foundation. Everyone should go to the website right after we're done, thehealingnet.org. On that are different resources that we've developed just to help people understand. When I was, when we first started, I said, we need to write a little book just to help doctors, to help nurses, to help caregivers, to help patients understand what the disease is. So we came up with this book called The Primer. It's not fancy. It's about like 10 or 15 pages long. It's in big print with a lot of pictures. So it's very, very digestible. I wrote it with my friends and my colleagues specifically to make it easily digestible for you and for the people around you. But then we found out it was important to understand how to navigate this journey, right? Like I told you, it's not just about the medicine. It's not just about the scans. It's not just about the surgery. What about the insurance? What about the wills? What about the finances? I mean, being sick can easily bankrupt you here in this country. So we created a document called Navigating the Net Patient Journal, again, in collaboration with our colleagues here at LACNETS. And it's a phenomenal document. I'm so proud of all my colleagues and our friends and the support we got from the different companies to really create something so powerful. Then we found out that there was a whole group of patients out there who have high-grade aggressive neuroendocrine cancer, and they needed something. So we sat down and we wrote this book called the High-Grade Neuroendocrine Cancer Book. It's right there. Feel free to download it. It's completely free. Share it with others, take it to your healthcare team, let them know that these resources are there. Because we are here to help you. I tell them all the time. I said, we create a healing net to help you because we want you to be well, we want you to live, and we want you to have time. And so those are the things that we have for you. So go to those resources. Sure, you may not get everything on the first bite. I got it. But you can't eat a whole meal in one bite either, right? So just keep working at it, and once you speak the language, you'll see that you'll speak the language, and it makes such a big difference. So let's talk about the NET specialist just for a tiny little bit, okay? Because I do want you to understand what I think, again, this is just me, what I think the NET specialist should provide for you. First of all, he or she should definitely be able to explain everything to you. Everything, all right? So I talk to people with neuroendocrine all around the world, right? I mean, if there's any one good thing that came from COVID, is that it expanded our ability to perform telemedicine. So I talk to people around the world all the time through this technology, which is significantly improved in the past couple of years. It's actually kind of cool. And so even just being able to talk to someone in India or someone in Turkey or someone in South America just helps them cope with it, because then they know, well, at least there's someone who understands it. At least now I get some of my questions answered, all right? If he or she can't explain everything to you, with a grain of salt, of course, but if they can't explain everything to you and what's going on and why this is happening and what we're trying to do and why we're deciding this, then you may want to just keep digging until you find someone who can explain everything to you. At least that's what I've been told. I've been told that a lot of patients and caregivers and families derive a lot of comfort when they can understand things better. It's not rocket science, but it is very, very complicated. Then that NET specialist should be able to help and guide you choose what to do, right? So if you're doing active surveillance, if you're going to have surgery, if you need imaging and those kinds of things, he or she should be able to help you decide what's best to do. Maybe it's not the right time. I tell people all the time, right? The art of neuroendocrine is not what to do. The art of neuroendocrine is when to do it. Because sometimes you can space these things out. You had a treatment. Well, you should milk that treatment for as long as possible so that we can give you more time, right? But then that NET specialist should also be able to give you options, right? There are things that I can do here at this hospital, which is why I work here, that I cannot do anyplace else, or that anyone else can do. And then people will tell you, oh, we can do everything. And the fact of the matter is they cannot, right? And I know that for a fact. So you have to find the right expertise. You've got to find the right options. You've got to make sure it's done by people who can do it for you safely and effectively. And once you know you have, all the cards are kind of laid out there, then you kind of understand what options you have. And what that NET specialist should do is they should take that burden off of you. I know a lot of you feel, and I know because you walk in here telling me, like, I felt like I was the only one, I was making all the decisions. Well, that's not fair to you. You're not trained to do it. You don't have the experience to do it, and you'll make a bad decision. Okay. So when you see a NET specialist, he or she should be able to take that burden off again. I tell that all the time. I say, just don't worry about that. That's my job. Your job is to nag me, make sure I follow up. Your job is to make sure you show up for your treatments. And your job is to make sure you show up for your testing, right? That's your job. You show up. My job is to think about it. It's true. For me, it's like playing 700 games of chess all at the same time. I'm not going to lie to you, right? So, I mean, I have to figure things out. I can't remember everything about every single person, right? There's so many people now. It's very difficult. But once I kind of get things up, I can definitely figure things out for you. That's no question. And hopefully that can help you feel more comfortable, right? Because now your team is full with someone who can guide you. Even though you're the captain of the ship, you still need a navigator, and that's where I can help you. But also I can do things that, like I said before, that some people cannot do. You cannot have at your local place. So we have specialized diagnostics, right? For a long time, no one could get a gallium dotatate PET CT. You had to fly all the way to me to have it done, right? Which is not fun. But now, thankfully, it is widely available. There are different forms of it. You can get it in Alaska, you get it in Hawaii. It's fantastic. And a lot of the treatments are widely available now, like the Lutathera treatment, widely available. Doesn't necessarily mean it's the right treatment. But there are certain things that require still specialized expertise. Surgery is one of them, unfortunately. Interventional radiology, very, very tricky sometimes. It requires a lot of expertise. So talking to the right people and having the right team is super important. right? And so that's what we will do. We will provide that team, or your specialist will provide that team that understands your disease. Now, I got to make it very clear to you, I am not your PCP, okay? And I'm not your PCP because I'm a terrible PCP. I am not trained to be a primary care physician, okay? So that's the whole thing. So if you want me to prescribe your antidepressant, you're asking the wrong person, because I don't really know what I'm doing. If you want me to fix, all your anemia, that's probably not the right person to talk to, but at least I can help and guide you through some of it. Okay, so just remember, your PCP is still a critical person in your care team. And don't forget, if you're not happy, you can hire another one, right? You hire me, right, in order to do this, to help you. If I'm not doing my job, you should not stay with me. I mean, I try my best to do everything for you, but I'm not perfect. I know I'm not perfect, right? So if you're not happy, you should find somebody else. You need to hire someone who can help you, right? And that's critically important. Do not let my ego or anyone else's ego or anyone else's feelings affect your life, okay? Period. If I'm not doing the job, I will not be hurt. I'm a big boy and I will not be hurt. Don't get me wrong. I want to be able to help you, okay? But if you get another opinion from someone else, I am delighted, because I want always what's best for you. And if someone doesn't want what's best for you, that may not be someone you want on your team. Okay, how about your local team? Well, what does your local team do for you, right? So if you live here in Colorado and Denver, I'm your local team, right? So that's actually very convenient. But if you don't live here, they can provide your routine care, right? Because if you're doing great, you probably still need a colonoscopy. You might still need your hypertension, your diabetes managed. You still might need your nutritional, whatever needs to be done. They can still provide routine imaging, right? So they can do the CT scans, more conveniently. They can and should and hopefully do communicate with the neuroendocrine team. It's not perfect. I told you, a lot of it's done through fax, so it's not perfect. But if we can still communicate, it's important. But what they can do is they can support you and recognize when you are sick, right? So a lot of people can thrive with neuroendocrine, but every now and then you get super sick. You get a bowel obstruction. You might have a pancreas problem. You might have breathing issues. You might have side effects from your medicine. All those things can make you sick, and you still need someone who can care for you. But it's important for the local team to kind of know when it's beyond their expertise and call upon someone to help them when things are a little bit complicated. I always start the conversation with, thank you so much for taking care of Mrs. X. And thank you for letting me know. Let's work together. We can take care of these things. And of course, they need to be willing to transfer or seek help when you're not doing well. And again, if you're not happy, you should hire another one. And again, if you live in a very rural environment, it may be difficult to do. I understand. But remember, it's not about the doctor's ego. It's not about hurting anyone's feelings. It is only about your well-being and your being healthy and your being comfortable. Well, so now what treatments do you do, right? And you've heard me say it now multiple times. You want to think about your quality of life first, and then you want to think about your quantity of life. The problem with the quantity of life is I cannot predict how long you're going to live, right? You can get hit by a bus. We've seen this in the news too many times. So I can't always predict your quantity of life, but goodness gracious, I can do everything in my power to make your quality of life better. And that may just be through nutrition, that may just be through education, but that may be through medicine, that may be through surgery, that may be through all kinds of different things. So I have a lot of, luckily, tools in the toolbox to help with both. But think of that. How do I improve my quality of life? How do I improve my quantity of life? Those are the two things in that order. So I tell people all the time, for a kind of unusual rare disease, we are very, very blessed to have a bunch of tools in the toolbox, right? So I am a surgeon. That's what I do for a living. I'm a general surgeon, right? So I still fix hernias and take out gallbladders. But surgery is a super, super powerful and a very effective, what we call local regional treatment. I cannot treat every single bone lesion. I cannot do all those things, but I can fix a bunch of things. And I have learned over all the years to fix a bunch of complicated things. And so that's a powerful thing. We have medicines that can suppress, that are hormones that can be suppressive. You all know that. We have hormones that can block the production of the hormones, make you feel better. Medicines, that block the hormone synthesis. We have targeted agents. We have chemotherapy. We have hepatic embolization. And of course, we have PRRT. So there are a bunch of tools in the toolbox. The problem is if you don't sit in front of someone who can guide you through it, which one do you pick? How do you do it? And who is qualified to do these things most effectively for you? And I know because I have to fix a lot of things. I have to fix a lot of problems, right? And so if things don't go well the first time, I got to fix it. So I get it. It's complicated. I understand the situation. But this is why it's so important to have this whole team around you, right, to help pick these things. So then I do think it's important to find support because it is difficult to do this alone. If you are initially diagnosed, you can be diagnosed in an emergency room, right? I mean, how horrifying is that? But that person will not know. So you got to go find the support. The good thing is there is a ton of support out there, all right? And these are just most of the websites that I know about. I'm sure there's way more. I'm sure Lisa can tell you more about it. But we have the Healing Net Foundation, right? Please come be a part of it, support it. We want you to be part of our community. But of course, you can see LACNETS has wonderful resources. We have a group called the Neuroendocrine Cancer Awareness Network, which helps support the patient support groups. We have the kinds of doctors groups, which are a little bit different, the North American Neuroendocrine Tumor Society, the European Neuroendocrine Tumor Society, the Net Research Foundation. Everyone is in the business to try to help you. They all have different jobs and stuff like that, and different responsibilities and different focuses. But there are definitely resources out there, so you're not alone. I get it. It's not colon cancer. It's not lung cancer. It's not breast cancer. But in some ways, neuroendocrine, when it's cared for very, very well, is almost more complicated in certain ways. And so getting to the right team at the right time and getting the right treatment is so critical. And I'm sorry if I sound like a broken record, except for the fact it's so important. So you got to find that right treatment, you got to find the right team, and you got to find it at the right time. And all those things are so critically important. And those resources are out there. Yes. Do you have to do a little homework? Yes. Might you need to rely on your caregiver? Yes. But that's why we're here. We're here to do it. Remember, sometimes you feel like, oh, it's a burden upon my family. It's a burden upon my spouse. I got it. Except for the fact, what's even more of a burden? My inability to help you, right? If one of my staff had a problem, all I would have wanted to do is help them. If my wife would, thank goodness everyone is healthy. But if my child or my wife was not well, all I would want to do is be able to help them. Right? So give them the room to help you. You're not alone. Okay, I have to assure you this. You may feel alone. And again, I know I'm probably preaching to the choir since you're all logged on. But there is support out there, right? I mean, whatever you think of social media, and I'm not going to lie to you, it can be a little poisonous sometimes. But there are wonderful things that do come from social media. For example, we have a group here just that we do called Dr. Lou Zebra, where people can commune and talk. It's not about me, right? But it's about a place where people can share their experience, help understand, and just know that they're not alone. And there are people from all over the world on that social media site. Here in Colorado, for example, we have the Colorado Net Support Group, and it's run by just amazing human beings who just want to help and just want you to feel like you're not alone, because you're not. And you need to find it. And if you need it, you need it. And don't feel like it's a weakness or that you're going to just talk to people who are just going to bring you down all the time. I mean, yeah, it's true. Some people are more sick than you. It is true. But if you're the one doing well, and I tell people all the time, if you're doing great, share your story. Help others. Be the one not only to receive support, but to give support. Because we're all part of this together. It's a community. And I just want to make sure that you realize that you are not alone. Sure, does it stink to have metastatic cancer? It's horrible. Is it scary? Is it financially draining? Is it emotionally draining? Does it change the way you look at life? Yes, all of it's true. But if you can live with it and gain control of it, it's an important part of how to cope and how you can still thrive with the disease. So this is actually pretty important. I have come to the conclusion that stress actually is an important part of people's disease process. I cannot tell you how, but what I can tell you is that stress is a hormonal process, and neuroendocrine is a hormonal disease. Okay, so it happens. So you have to just accept the fact that it happened. You had this diagnosis. You don't have to say, like, what did I do wrong? Why me? It happened. And the problem is it happens to people in all crazy situations all the time. But what it means for you is that, yes, you do have a second job, but it also means that you know something about yourself that others do not. it means that you might know how you'll die. Right? And so that's not easy to face, right? It's difficult to face the fact that you're now dealing with this. But it doesn't matter, because what I can tell you is that the major risk factor for death is life. 100% of all humans in all of history have died. That's just how it is. The reason that it's a little bit easier to deal with is that I just don't know when it's going to happen, right? I don't know why it's going to happen. I don't know how it's going to happen. So maybe ignorance is bliss. What's different for you is that you might have something that might be causing this. So it's difficult to deal with. I understand. It's stressful. It is horrifying. It is scary. I get that. But how do you kind of gain control about it? Well, one of the things I tell people to do is do not constantly have your mind thinking about every single possible outcome, every single possible treatment, every single thing, right? This is why it's good to have a Sherpa, to have a neuroendocrine specialist who can take that burden off of you. Because if you think about every little thing that's possible, it's all you will ever think about. And you will never have the space to enjoy the time that you have here, right? I work incredibly hard to give all of you, or, for the people I take care of you, to have the time to think about something else. And I tell people, well, what about this? Well, what about this? What about that? I'm like, stop. Don't think about it anymore. I don't want you to waste your mental energy on that. That is my job. That is my chessboard to play for you. And so once we can kind of get you past that, I think that helps a lot. And the way I tell people is that, look, what will happen is you'll get one piece of information, you'll get a piece of data, a scan, a lab, a biopsy, a surgery, a result, whatever that is, and then you'll make a decision. And that's what you do. You'll get a piece of data and you'll make a decision. And you'll get a piece of data and you'll make a decision. And then you don't have to keep thinking about it, because I can't even make that decision for you until you get that piece of data, right? So you might as well not think too hard about it in between. Sure, again, you got to show up, you got to take your medicine, you got to do things you got to do. But as far as freaking out about every single possibility, it's just a waste of your emotional energy. And I know it's easier said than done. I said that from the very beginning. I know it's easier said than done. But once you can start to understand that, that's when life can come back and you can start to live again instead of just being absorbed by this disease, right? And one way to do is to find other outlets, right? Here in Colorado, people love to go hiking, exercising, right? Because my whole goal is for you to live your life. And what you want to do is you want to allow yourself some time to just forget about the disease. Just sometimes let it go, let it be. And once you can have that time, again, you got to do the things you got to do, but you need that time to just be a human being, to not have to be a patient all the time. Because if that's a situation, and then why am I working so hard to keep you well? I work so hard, my whole staff works so hard, so you can have that time to forget about the disease for some time. And that is my goal. And hopefully if you can begin to see that, then you can start to live with disease. So I tell people, you do need to care for yourself. But at the same time, let others care for you too. That's what we're here for. Right? Yes, there's a lot of data. Yes, there's a lot of tests. Yes, there's a lot of surgery. Yes, there's pain. Yes, there's suffering. Yes, I understand that. But we need to do that because we need to care for you. It's a group process. You have to have a whole team. And so then and only then can you really live with it. And it's true. I'm not going to lie to you. There are some horrifying neuroendocrine cancers in which I cannot stop it, and patients die a month after diagnosis. It is so scary. It's scary for me to see. But luckily, a lot of time, people can actually really do quite well. It can be an extremely indolent disease, or it can be slowly progressing and still not hurting the patient that badly, or the patient can have symptoms that we can help manage and they can still live better. So if we can get you in that field in which your feelings are pretty good and your quality of life is pretty good and things are going pretty well, then I'm doing my job. So you care for yourself, you make the decisions, you let us help you, and that is the way that you can live with neuroendocrine cancer. So again, you're not alone. Do me a favor, go to the Healing Net Foundation, take a look at it. There's a bunch of resources there. Hopefully that will help you. You can see this is just a handful of the people 5 or 6 years ago when we started the foundation who were just a nucleus of getting the thing going. But now there are many, many doctors who have a real interest in neuroendocrine. You saw a lot. I don't even know a lot of those doctors in that video from the LACNETS you already saw because they're new to our field, which is fantastic. Anyway, now there are many, many, and that was one of the goals of the Healing Net Foundation, was to increase the community, improve the community, so that there are more people who understand the disease and can help you. Again, go to the primer, download it. It's totally free. I think it's a great resource to help you and to help people around you take better care of you. And just know that there are lots and lots and lots of people who want you to thrive and do well. And this year we're going to have our Healing Net Foundation Summit again, where we can get all our friends back together and we can talk and figure out new ways to help you. The Net Vitals was actually, and Lisa can tell you, was actually a program that came out of one of these meetings. We all sat down and we said, we need to do this. And LACNET said, we are going to do it. And I couldn't be more proud of them. So again, just know that this is hard. This is unfair, and it is brutal sometimes. But if we can help you live with your disease, then you can live your life. And that's all I want for all of you. That's all I have today. So if we want to do a little question and answer, Lisa, I'm certainly available to do whatever you want.
Okay, well, let's go ahead and get to some of the questions, if that's okay. And there are several questions. I know that, and thank you for your really encouraging message of support, of empowerment, and really just recognizing and reminding us all that we're not alone. So, of course, questions come up regarding time and how much time there is and how much time things will work. So this is one that was very popular in the Q&A. What is the progression-free survival for pancreatic NET with metastasis to bone on sandostatin treatment?
Wow, that's a very actually more difficult question to answer than you think, because it's sandostatin actually. So sandostatin specifically is octreotide, as you all know, right? It's the LAR version of it. And it is actually not that well tested in metastatic pancreatic neuroendocrine tumor. It's much better tested in small bowel neuroendocrine cancer. So the progression-free survival, okay, so that's actually even more complicated than you think, because really knowing when a person progresses can be a little bit difficult. The question is, how much do they progress? Where are they progressing? What type of progression they have? Do they have new lesions? So you can see here, when people ask me to just like cure them over the internet, I can't do that, right? Because there's so many things that are involved. I need to study the case. But the progression-free survival for the patient on sandostatin treatment, at least for small bowel neuroendocrine, is probably in the roughly year range. What that means is if you start sandostatin, especially at high doses, that's the best data we have, it helps to slow it down for many, many months, but it can still progress. The question is, what does that progression do, and how is it going to hurt you, right? So I actually tolerate progression in people a little bit, because if it's not dangerous and I know I can still do stuff and treat it, how big it gets probably isn't that important. Progression-free survival, just so everyone understands, is basically what it means is, what is the time period between starting a therapy, and this is for the clinical trialists really, right, the people who do the research. When they start the therapy, how long can they hold the disease stable before the disease grows or you have new lesions? Okay, that's kind of just roughly how it is. That's particularly important because it correlates really well to like deadly cancers, brain cancer, lung cancer, breast cancer, and stuff like that. So it's a very good indicator for those things. It's not perfect for neuroendocrine because a lot of patients will progress and just slowly progress, and they can still really do quite well. So it may not necessarily, it may be kind of a prognostic for survival, right? Because it's survival that I'm worried about, right? How long is someone going to live? That is the end all be all, and that's what I want to know. But the progression-free survival kind of gives you a sense of whether the treatment is effective or not. And that's kind of where it is. So sandostatin is not super well tested and indicated and effective in metastatic pancreatic neuroendocrine tumor, but we use it because the risk is very, very low. We have some correlative data with another medication called somatuline or lanreotide, which I'm sure a lot of you take. So knowing that the mechanism of action is very similar, we kind of draw similar kind of conclusions. And because the medication is so safe and so widely used, we start with that. But then the other question is, maybe you had the bone metastasis for a long time, and this is the first time you had a dotatate PET CT and you found it. So it's complicated. So I'm sorry to take so long on the very first question, but it's complicated.
Yeah, it's not an easy one. And perhaps this is a little bit of an easier one. How long can a patient safely continue on lanreotide, or in that matter, sandostatin, octreotide?
Sure. So the great thing about lanreotide and sandostatin is we have years and decades of experience with it. So we have a good understanding of it. Lanreotide and sandostatin or somatoline is the name of the drug here, they're both very, very safe. And so you can be on it for some patients for decades. Now, it's not perfect because it is a big shot in your behind, right? And sometimes they can scar, and especially if it's not given correctly, it may not work so well, and you can have scar tissue and it can be difficult to give the shot. So there's a lot of nuance to it, but in general, the medication can be tolerated for years, which is very helpful because there's some patients who are on it and rely on it for years.
Yeah, thanks for that. And another similar or in the same vein with the somatostatin analogs, why would you continue on octreotide shots after PRRT? Particularly, this person had bone net progression that led to PRRT after being on octreotide for 17 months prior to PRRT.
Right. So the problem is you're putting too much faith into PRRT. PRRT is a therapy. It's a very effective therapy. Okay, it works for certain people better than others. It works for certain types of neuroendocrine better than others, right? So there's a lot of nuance to it. So the real question is how can we optimize your ability to do well, right? And so one of the things is if the PRT kind of gives you a big jolt and a big bolt as far as controlling your disease goes, can the octreotide shots still keep everything nice and quiet? Those are two different mechanisms of action. The PRT is a delivery of radiation at the cellular level, okay? And the octreotide, in addition to having effects on the tumor, may have effects on the whole endocrine system, which help to keep the disease more quiet. So if you've been on octreotide for 17 months and they decide you're progressing and they decide that PRT is the appropriate therapy for your bone metastasis progression, then still keeping the octreotide on board may help to keep the disease quiet. And of course, if you have symptoms, then it's still the best way to treat your symptoms, right, from the carcinoid syndrome or whatever that's going on. But it is definitely having two modalities of therapy to slow down the growth of the cancer.
Yeah, thanks for that. So there's some surgery-related questions. So if a surgeon didn't get all the primary tumor, even though the report says they got it all, but they didn't, is this what spreads the net to other areas and causes more tumor?
No, this is absolutely not true. So the problem with neuroendocrine, it's despite the fact it has a reputation, which it mostly is true, it has a reputation of a relatively indolent disease. It is highly, highly metastatic, right? There are a lot of people who spread very, very quickly. And so a lot of people walk in the door and they already have metastatic disease. So it's a real problem. But what I tell people is, and I know this from experience, like, I do some amazing operation, I pat myself on the back, like, oh, look at me, I'm a hero, and then the disease just comes back. And I know this because for a long time, I was the only one who had this gallium dotatate PET CT. And so I would find all this metastatic disease in all these people who thought that they were cured of the disease, when in fact they had it the whole time. We just couldn't see it. So that's the problem. So I've just come to the conclusion that, don't fool yourself. If you had the disease for if you've been diagnosed for 5 months, you probably have had the disease for 5 years. So if you've had it for that long, then the chance of it spreading at that point is pretty much 100%. So if it has the personality and the biology to spread, it's going to spread. So even if you can't get the primary tumor out, it probably doesn't alter the kind of course of the disease. The reason removing the primary is helpful is because it usually helps with the symptoms and the survival and the nutrition and the well-being of the patient. So that's why, at least for me, I think getting the primary out helps people live better. Because imagine if you have a primary tumor that continually constricts your intestines and you're trying to eat through a tiny hole like that, you're not going to eat well and you'll have pain and you'll be under stress. So getting that cleaned up helps people a lot.
As you can imagine, there's several questions with like, I have this size tumor here, can this be resected? But this one I think kind of encapsulates many of these kind of questions. So my husband has a large PNET with blood vessel involvement. He's finishing CAPTEM, which shrunk it. What questions should we ask our surgical consult?
Well, the most important thing is, have you had a complete workup? So that means, have you had a dotatate scan? Do you have disease outside? What are you trying to accomplish? There are a bunch of blood vessels, so I don't know which blood vessels. How are you going to fix that? How are you going to address it? If it was very, very large, could other organs be involved? I mean, the questions are quite extensive. And the most important thing is, how much experience does the doc have? Because they can be quite experienced with pancreas cancer, but pancreas cancer is a completely different animal compared to neuroendocrine, right? So what we call ductal adenocarcinoma, it's completely different. We think about it differently, it behaves differently, it acts differently, it binds differently, it grows differently. So just because someone has a ton of experience with pancreas and they may think they have a ton of experience with neuroendocrine, it can be just a little bit different. So I don't really know what questions to ask, except for the fact that you want to know the full extent of disease, what is the bailout, and what's going to be like, what can really, really be involved. So one of the most irritating things that bother me, and this is just personal, is that doing any kind of operation is a big deal. Okay, I'm not gonna lie to you, right? Doing an operation on the pancreas is a super big deal, and sometimes, and these are my colleagues, so I will say this, that sometimes they don't always tell the person that things will not be always so great on the other side, and they just say, "Oh, you'll be fine." Well, that's not exactly true. And so you just want to make sure that you also know exactly, well, what will I be like afterwards? What are all the risks? What do I need to be aware of? That's super important.
Yeah, and so, one of these questions about is it possible to resect is this person has a pancreatic net and the size is 6 centimeters at the head of the pancreas with liver metastasis. So is it possible to resect this? And how do you have these conversations with patients?
Well, the answer to your question, Lisa, or this question, is that I can resect anything. I can do anything. Right? I mean, I can remove every single tumor essentially. But the question is, what is it you're trying to accomplish? What are the risks and how do you feel now, right? So am I just trying to do an operation to make your scan look better? I mean, is that like a great indication? Or is the patient so sick because they're blocked in their veins, or there's some threat or something will happen, right? So sometimes a patient will be perfectly well. And I know that because of the way that their scan looks, something horrifying will happen. So sometimes we will do very risky, complicated operations because I can avoid that. I mean, I have patients who've had like these problems because the surgeon felt like the tumor was unresectable when we could have, admittedly kind of heroic, but we could have done something about it 10 years ago, 7 years ago, 5 years ago. And now I can't do anything about it because it's too difficult, too tangled. So the answer is yes, it is always resectable. But the question is, what are you trying to accomplish? How am I going to improve your life? And how am I going to extend your life?
Life is important, as you said, and living it fully and richly. So this question is about the side effects of surgery. So do you have patients who experience chronic constipation after low anterior resection? What are the reasons for this and how do you manage it?
Well, the most important thing is you need to talk to your doc. But for those who don't know, a low anterior resection is a removal of your rectum. Okay, so basically, so if your anus is the hole, the actual hole itself, this portion of it is called the rectum. Okay, and a bunch of neuroendocrine tumors come from this area. And then when you do it, you remove this portion of it and you bring the colon down, you attach it kind of down here is how it works. So that's called a low anterior resection. So it's a rectal, we call it a rectal resection. Now, people do have that. People have constipation because, there's a reason why God created a rectum, right? I mean, if there was no purpose, then we wouldn't have created it. So not having a rectum is not perfect. A lot of people actually do very, very well. Don't get me wrong. They do really great. But if you have chronic constipation, there can be a lot of reasons for it. So the number one thing is you got to talk to your doc, period. So talk to your colorectal surgeon or your surgical oncologist, whoever did the operation. 2, talk to your gastroenterologist. 3, talk to your local oncologist and talk to your local people, okay? So try to figure that out. But we have lots of different laxatives. So you got to figure out why you're having chronic constipation, right? That's actually the most important thing. So once you got to figure out why, then there are a whole bunch of different things we can try. It's not perfect, but there are a bunch of different laxatives and medications that we can try that can help you kind of become more regular. Because chronic constipation stinks. It hurts. You're holding toxins inside you. You can't eat well. I mean, it's rough. I get it. And so we have to find some reason why and how to treat it for you. But there are multiple reasons and there are multiple managements.
It requires a discussion. And talking about discussions, and you see this, a lot of people are getting different opinions from NET specialists. So how do you advise patients who are getting different opinions from NET specialists?
Yeah, I get this all the time, like all the time. They'll have seen like 4 other docs and finally they end up with me. And I'm like, oh yeah, you saw Doc X and he told you this, right? And you saw Doc Y and they told you this, right? And I'm just like, yeah, I get it. And then I get it the other way too. The people will see other people like, oh, Eric told you this, right? And they'll be like, yes, that's what Eric told you. So the problem is it is difficult, and I get it. And the reason this happens, so just so for you to understand, is that neuroendocrine is actually a relatively forgiving disease, okay? So if you're driving through like a superhighway, right, a 6-lane superhighway, the goal that we want is to keep you going straight. But you can veer off a little here and there, and a lot of it's timing, whether you do it now or later, or, what you choose. I mean, there's a lot of flexibility to it. And that actually makes it more difficult. Because if you see 7 people, the 7 people will probably not totally 100% agree, and that becomes a challenge for you. And so sometimes you just got to bite the bullet and just choose the person you trust the most. And if he or she cannot explain to you why, they made that recommendation to you, then you have to rethink it, okay? And you can just say, hey, look, I saw this person, they said this, and I saw this person think this, and what do you think of this, and what do you think of this? And then you have to just choose who you trust the best, who makes you feel most comfortable. And that is kind of the hardest part for the patient to do, because how do you know? Right? How do you know? And so, I'll say, yeah, Dr. X's recommendation is very, very reasonable. We can go with that. But you might want to try this because of this reason. And if you think that reason is important to you, then you would go with that.
Yeah, we don't have that magic mirror or a magic 8-ball to tell us what the end result will be. So along those lines, about not knowing, so there are people who consider flying for a surgeon. So should someone fly? And more importantly, if so, how's that managed logistically? I know people come and fly and see you.
Well, I can tell you how I deal with it, and I don't know how anyone else does it. I can only tell you how I deal with it. So it's true. A lot of people fly for me. I'm not sure I'm a good surgeon, but a lot of people do fly here. And luckily, we have a big airport. It's very, very central. It's like not that difficult and complicated. Usually what people do is they will come actually once, and they will come kind of get a lay of the land, figure things out. They'll come for their appointment, maybe their scans or whatever, and to meet me, which I think is important. I think it's really important to meet the person who's going to be doing this for you so you can develop that trust. And then usually what happens is people will fly in, let's say on a Monday, and then let's say they'll do their testing and their scans and their preoperative things. They'll go to the hospital on Tuesday, and we'll chit-chat on Tuesday, and then we'll do their surgery on Wednesday. And then I don't kick people out of the hospital, especially when they come from very far away. I want to make sure people are safe and they're okay. And then they'll be in the hospital, let's say, for a week, randomly, maybe longer, depending on the complication, the severity of their operation. And then I usually ask them to stick around for a few days in an Airbnb or a hotel or something so I can watch them, because I want to see how they function as human beings, right? If you're going to get pneumonia, God help me, if you're going to have a heart attack or you're going to get a blood clot, right? That happens. I want you to be close to me because then I can take care of you and we can figure things out before you go home. Sometimes people have like drains. Sometimes people have like medicines. People have other things that are going on. So we kind of have to manage things a little bit before they go home. And then once they really feel comfortable, and sometimes they're stuck here for a little bit of time. Once they're doing well, they usually make that trip home, and then they're usually okay. So I have people fly home after surgery all the time.
That's helpful because you do have experience with this. And the next question would be, what does a patient do when they fly out of town for surgery with a NET specialist or surgeon with no one for post-surgical care when they get back home?
It's not perfect. It is not perfect. And, obviously, again, for me, we're always available, right? So by phone call, by portal, by, whatever. And we have all kinds of ways of communicating. And so we do sometimes rely on the primary care physician. We do sometimes rely on the local doctor. And sometimes, unfortunately, patients will be like, well, they'll see a doctor like, well, that's not my problem. You shouldn't have traveled. You should have, let me do your operation. And so that is not great. I'm not going to lie to you. It is not perfect. But frequently people can, go to the hospital, and the hospital is usually pretty good about taking care of you. And then just hope that the physician can be supported. Like I take care of a bunch of patients who like go and fly and have like all kinds of weird stuff, right? They'll go to some specialist in not necessarily neuroendocrine, but they may have like some specialist in some other kind of cancer, and they'll come back and I'll take care of them. And I'm like, yeah, no problem. You tell me what to do. I will take care of them. I swear. It doesn't always work that way, and so it can be a challenge. But I'm always here, and we can always help you as best we can.
Yeah, you definitely do help people, and we really appreciate that. So, I'm going to transition back to treatments. People are on medications like lanreotide and Afinitor. Do they make patients diabetic, and how do they affect the body to make that happen?
So the answer is kind of. So lanreotide and Afinitor, one of the side effects of them is both hyperglycemia. It doesn't happen in every single person, but that means their blood sugar goes up. Okay. Afinitor is a medication called everolimus. I don't know if I want to say it necessarily makes someone absolutely diabetic, because there's a very clear definition of diabetes. If their glucose is above, fasting glucose is above 125, which is obviously a kind of a hard fast rule. But really, the problem with diabetes, it makes people much more labile, right? So their sugars are kind of going up and down their day. It becomes more difficult to manage. It's because their pancreas can't do that work anymore. And the Afinitor and lanreotide can kind of make that a little bit worse. So, it might raise the blood sugar not only just to a certain kind of new resting point or average point, but it might make that lability a little bit worse. So it's not that it actually, gives people diabetes in the sense like, it causes type 1 or type 2 diabetes, those which are very two different things, but it might make it a little bit worse. But it's a side effect that we have to watch out for. And that's how it affects the body to make that happen, because it usually affects the ability to secrete insulin and glucagon and the hormones that affect it. And it's a side effect of the drugs.
And, as you know, many people worry about kids and genetics. So what is the risk to children of this disease in the absence of any genetic marker, specifically for small intestinal NET? Should they follow any specific monitoring protocol?
I don't think so. We don't have any good markers for genetics for neuroendocrine, especially small bowel. So usually what happens is, and I know this sounds crazy, but usually when you find out someone has it, you just find out if someone has it in their family. And I know people are working on it. We have colleagues in Europe. We have colleagues at Bethesda who are working on it, but it is not it is not established at all. So what I usually tell people is it's usually just a strike of lightning. The chance of it affecting your kids I've seen so many patients who have neuroendocrine in which it doesn't affect their children at all because they get it when they're older, that I say it doesn't affect it. Unless the child develops symptoms, you might want to have a slightly lower threshold to start looking for it.
And then how would you look for it?
Well, the easiest thing is just to do a CAT scan. I mean, a CAT scan is fast, it's cheap, it's easy for people to read and understand. If it comes back negative, I mean, CAT scans aren't perfect, but if it comes back negative, at least you don't have like some horrifying cancer roaring through your child's body. So just start with that.
Okay. This person has been living with NET for 16 years, since June. What side effects comes along our way the longer you endure this cancer?
I don't know the answer to that question. Most of it has to do with actually kind of long-term effects of whatever the treatments are. So, for example, if you've been on one of the shots for a long time, you can have like nutritional pancreas problems for quite some time. You can have like, injection problems too, just from the scars. People can also develop, let's say, scars from the tissue, so you can get bowel obstructions. If it comes from the lung, people can have like long-term respiratory issues too. So usually, if people have been doing well for 16 years, they're actually using pretty well, and that there isn't a whole lot of surprise that comes along the way.
Congrats on 16 years. That's amazing.
Absolutely.
Yeah.
Congratulations.
So, there were a couple questions on carbozatinib. So I thought we'd just go with this question. Is there much of a difference between carbozatinib and surfatinib? And if you know any results on how each clinical trial is going for these two drugs?
Well, I have no magical information. I have no inside information. Even if I did, I couldn't tell you, right? Because it's part of a trial. So, but what I will tell you is that the cabozantinib trial is going, and we'll see. The big difference is that cabozantinib is available in the United States and surufatinib is not available in the United States. They are both what are called tyrosine kinase inhibitors, and they affect kind of like the signaling and the way that the molecules inside the cells work. Cabo is approved for other kinds of cancers. Suru is not. It's a drug that's unavailable in the U.S. and it comes from China. So they need to do more trials in order to get that through. But at least the the data that they have so far is very encouraging for surufatinib. It seems to slow down the growth of the tumors. It's a little bit better tolerated. It works both in pancreatic and what they call extra pancreatic, so outside of the pancreatic neuroendocrine. But we'll see. So I'm hoping that we'll have more tools in the toolbox in the future. But the clinical trial is helpful. It gets it registered. It determines kind of elements of safety. But you never really know how a medicine works until you use it in the real world. And then we'll find out. PRT is a good example of that. I mean, you can talk to the docs as much as you want. You can read the papers as much as you want, but you never get the real inside information until you actually do it and watch hundreds and hundreds of people go through the process.
Yeah, thanks for that. And we look forward to hearing more. So we're just going to do a couple more questions. One is, well, what is the significance of subcarinal nodes in terms of treatment and predictive overall survival?
Okay, so a subcarinal node, just so everyone understands, is a tiny little lymph node that's right at the kind of like the middle of your lungs. Okay, and it is classically a very common place for lung neuroendocrines to kind of creep along and go. But you can also have what are called mediastinal lymph nodes from the belly. So the answer to the question is I don't really know. I mean, all it means is that it's metastasized to a chest lymph node. But again, all of the other information means a lot. So I can tell you nothing about a specific subcarinal lymph node.
This question is a common one. Is increasing chromogranin A a concern, even if there's no change in symptoms and all other blood work is normal? I'm sure you never, ever get this question.
So I have very strong feelings about labs. So just this is me, okay? People differ from me. My elders differ from me. Last time I checked, no one's died of a chromogranin overdose. So if it correlates with increases in your scan, if it correlates with, well, in this case, no symptoms, right? So if it correlates, it might be helpful in deciding if there's like some disease progression. I got that. And then the scan is really what is the end all be all. But just a rising chromogranin in and by itself is not super, super helpful. It's more about the scan.
Yeah, thank you. And we're just going to end on this question and any closing thoughts that you have. I know everyone wants to ask you a zillion questions. We have like 30, almost 40 questions, and it's just not possible to get to them all. You know, we talked about living with the disease. So do carcinoid tumors ever go away?
I'm so glad that there are 30 or 40 questions because that means people are engaged. That engagement means a lot to me. Not only for, I mean, Lisa knows. I mean, she's dedicated her life and her career and her loved one, obviously, to this. But it means that our community is growing and people feel comfortable asking questions, which is fantastic. So the answer is, do neuroendocrine tumors go away? They go away all the time. They go with a pair of scissors, a knife, and a cautery device. That's how they go away.
Okay. And you know, we just want to thank you for this just comprehensive, like holistic view that you took with your presentation. And I just wanted to invite you to see if you have any closing thoughts as we close today's presentation and webinar.
Yeah, I just want to let everyone know. So, I mean, Lisa's actually a life coach. She understands the global aspects of what it is to be a human being. And that's really what it is. Look, I hate to tell you this, disease, famine, poverty, suffering are all part of what it is to be human, right? But at the same time, joy, love, experience, learning, knowledge, all those things are also what's part of being a human. So if we can kind of manage the first elements of them, the bad part, and enhance the ones that enrich you, that's really what I want to do. Because I do this every day, and it's exhausting. I'm not gonna lie to you, it's exhausting, and it can be a little depressing sometimes. But when I see people feeling well, like we're about to discharge a guy who was sick. I mean, we walked in the door, and I did his surgery, and he just feels great now. When I see that, that gives me joy, and then I know that I'm doing my job. And if we can do that for you, then you can enjoy the life and the gift that's been given to you.
That's so important. And look what I happen to have here, the Navigating the Net Patient
That's my
Journey, which we're
girl.
talking about. Yep. So thank you so much for all you do. I mean, of course, surgery and taking care of patients, and then the Healing Net Foundation and all the collaborations and that you have with scientists and researchers and other providers and patient advocates, and what you're doing with Facebook Live and all the all the collaborations you have. We really appreciate all you do and look forward to hearing from you again.
All right. Everyone be safe. Be well.
Okay.
Bye.
I'm going to send it back to Rich in the studio.
Thank you, Lisa and Dr. Liu, for a fantastic Q&A. Be sure you're following LACNETS on social media. We have Facebook, Twitter, and Instagram. Stay up to date on upcoming webinars and net news. And now I'll pass it off to Lisa to close us out.
Thanks, Lindsay. We offer many programs and resources, including our weekly virtual NET support group, a dedicated monthly caregiver-only support group, NET Vitals, and health coaching, which is available to NET patients or caregivers. We encourage you to go to our website, lacnets.org, to find out more information about our programs, view resources, read blogs, take NET quizzes, and much more. LACNETS has developed a couple tools that helps patient and caregivers learn to speak NET. In 2018, we developed NET Vitals with the help of Dr. Dan Lee. NET Vitals is a patient-physician communication tool that helps you prepare for your medical appointments by filling it out as a self-assessment tool. So it gives you the opportunity to look some things up before your appointments, and it highlights the questions you have for your NET expert. It also helps you organize all the vital information about your NET in one document. This year, we also developed an abbreviated NET Intro tool as a way for you to share your NET history with someone who needs to understand key information about your disease. It basically includes the first page of NET Vitals. We found it's useful to use in our weekly support group when introducing yourself or when talking to NET providers to be able to quickly summarize the essentials of our NET cancer in just 2 sentences. So it might be useful when you see a NET expert at a conference. So instead of taking 15 minutes to tell your story, you can bottom line the critical pieces they need to know about your disease in just 2 sentences and then be able to get to your question. It's also useful in our support groups as it allows us to be more efficient in our introductions and allow more time for networking. Go to our website, lacnets.org/netintro for detailed instructions on how to build your NET intro. We've also created a printable wallet-sized card that you can fill out and carry your own NET intro with you and have handy, so you can pull out your NET intro card to read your 2-sentence NET intro to your medical providers. And we encourage you to practice with other NET patients or caregivers and in your support groups. We want to give a special thanks to our weekly support group whose input and feedback were valuable in developing this tool. NET intro is also available on our website in Spanish, thanks to Michelle de Quevedo from NETS Mexico, who has graciously translated the information. Did you know that LACNETS has a podcast featuring local NET experts who answer the top 10 questions in their field? We release 1 episode on the 15th of every month. We hope you'll take a listen. Thanks again to our special guest for today, Dr. Eric Liu. We're grateful for all you do for the NET cancer community, for your passion and support and collaboration. And thanks to Rich at TVP Live and to all of you for joining us today. Goodbye and see you next month.